We will discuss today the lecture on radiation therapy. So in the course of medical physics, there will be more detail, but it's important that we discuss in any case, now that we have seen the deterministic effects of radiation, that we go into the main application of radiation in medicine, which is radiotherapy. Radiotherapy, the so-called good side of radiation. So radiotherapy is also called radiation therapy, is a part of multidisciplinary approach to cancer care, which includes, of course, surgery and chemotherapy, or in general now drug therapy, including targeted drugs and immunotherapy. Is useful for approximately 50–60% of all cancer patients, but generally a smaller fraction can actually receive it. Is also given for palliation of metastatic patients, not for cure. Is, of course, apart from the combination with immunotherapy, used for local regional treatment, and the benefits and the side effects are limited to the areas being treated. So the important thing, I mean, we probably already mentioned this, is that radiotherapy is all about the therapeutic ratio. So the ratio of the probability of tumor control divided by the probability of normal tissue toxicity. Only for palliation, we don't care very much about tumor control because we don't want to control the tumor. I mean, but of course, we still care about the normal tissue complication probability, the NTCP. So the ratio is what really matters. And the ratio comes, of course, from the curves that are sigmoid curves for the tumor control and for the normal tissue complication. We want to prescribe those where the tumor control is as high as possible and the normal tissue complication is as low as possible. And this separation of the curve is called the therapeutic window. And somehow the role of the medical physics is to widen the therapeutic window. In fact, this is as it looks like. You see the TCPs in green, the NTCPs in red. You see that eventually at very high dose, both go to 100%. The absence of normal tissue complication is in black. This is the 1 minus NTCP here. And this is tumor control without normal tissue complication. So you see now this curve here, which is essentially TCP minus 1 minus NTCP is here, and you see that the peak is around here. This is where you have the higher tumor control for this dose without normal tissue complication. So, but what are the normal tissue complications? We saw them already when we discussed the deterministic effects of radiation. But to give you an idea, again, we have to distinguish in acute, late, and long term. Acute means fatigue is generally a typical systemic acute effect of radiation, but the others are very much dependent on the area. So you can have mucositis, esophagitis for head and neck tumors. You can have nausea or diarrhea for abdominal tumors. You can have redness of the skin a little bit everywhere, but especially for breast cancer, where the breast skin is very sensitive. Late effects that, as I said, are much more significant include, but are not limited to, pneumonitis and fibrosis of the lungs, somehow similar to the COVID-19 effects, hypothyroidism, xerostomia, enteritis, infertility or menopause. And finally, long-term, that can occur even after 10–20 years, are increased risk of secondary cancer and increased heart disease if the chest region is treated. These are only some. We have seen in the deterministic effect lecture that there are many, many different effects depending on the organ that is exposed. We also saw that the basis of radiotherapy is given by the so-called 4R that now became 6R. The original 4R were repopulation, repair, redistribution, and reoxygenation. So these 4 points give a rationale for fractionation, because of course, if you have fractionation, you will spare the normal tissue because you have repopulation and you have repair, but you will sensitize the tumor because you have redistribution in the cell cycle and reoxygenation of the hypoxic parts. Recently, as you know, other two R's have been introduced. One is the intrinsic radiosensitivity, which determines the genetic sensitivity of every different tumor. And the other one is the reactivation of the immune response, which eventually can be the real solution for the cancer problem if we can reactivate the immune response and so attack both the primary tumor and eventual metastasis. Now, let's make a very simple example. Let's understand why tumors are killed by radiation and what are the typical doses uses. So if you remember the lecture on cell killing, the intrinsic radiosensitivity of tumors changes very much. But if you look on the average, a dose of 2 gray corresponds approximately to 50% survival. So if you give 2 gray, you have 50% survival. How big is a tumor? Also in this case, very big variability, but to give you a typical value for a pretty big tumor, but not enormous, let's say 10 centimeter diameter, this means half liter, 500 ml. This means approximately 10 to the 10 cancer cells, but out of these 10 to the 10 cancer cells, if you remember the biology of the cancer, you have approximately 10 to minus 3 cancer stem cells. So let's say something like 10 to the 7 cancer stem cells. And as shown here, you really, but this we already saw in the biology lecture, you really want to eradicate the cancer stem cells, because if you don't eradicate cancer stem cells, you will have relapse. Typical, the old conventional standard fractionation regime is 2 gray per fraction, 1 fraction per day. So you have to go every day to receive 2 gray. So the question is, can we kill the tumor? How many fractions we need to kill the tumor? So if we completely ignore repopulation, repair, the 4R, let's say, we only imagine that every day we give 2 gray and every day we kill 50% of the cells, the calculation turns out like this. You see, if you have after 2 gray, you will have 5 per 10 to the 6. After 4 gray, 2.5 per 10 to the 6, and so on and so forth. You see, so every day you have a half, and you see we skip the weekends that normally you don't have therapy in the weekend. So from day 5 to day 8, now you have 1/2. As I said, we ignore repopulation here. There's no repopulation in this plot. And then you see that once you are approximately at day 30, if this is true, you see at day 30, day 31, you start to go below 1. So you can say at this point already that you have actually eradicated the tumor. So this is a dose of approximately 46 gray. The classical treatment plan is 2 gray per fraction up to 60 gray. So it's 30 fraction. We will see it changes very much, but originally this was the standard, and you see the rationale here. What is interesting, of course, this is a very rough exercise, but what is interesting in this exercise that you immediately get one thing. If instead of half a liter, you have 1 liter, so you have a double tumor, a tumor whose volume is 2 times bigger as this one, you don't need the double dose. You only need 1 day more, let's say, because this only means that the number of cancer cells is not 10 to the 7, but is 2 per 10 to the 7. But if it is 2 per 10 to the 7, you only need 1 more day, and you can treat also the large tumors. This is why the same protocols apply to large tumors and small tumors, at least traditionally, let's say. Now, we will see that many things changed recently, but until a few years ago, the schedule was almost the same, 2 gray per fraction, 60 gray in total. Independently on the tumor and independently on the volume of the tumor. Now, as we have seen, fractionation has a strong effect on late effects, on normal tissue toxicity. These are all data from mouse and pig experiments. You see, this is the skin reaction as a function of the dose for single dose irradiation in mouse. And this is the skin reaction as a function of the dose when you have 10 daily fractions, same dose, but in 10 daily fractions. You see that the NTCP, this is actually an NTCP curve. The NTCP curve moves to the right, which is exactly what we want, moving to the right. For pig, skin reaction in pig, this is a late effect. This is more an early effect. This is more a late effect. You see the single dose, and you see how the fractionation regime, 5 fraction in 28 days, 9 fraction, 21 fraction. If you increase the number of fractions, the NTCP curve move to the right and to the right. But the real effectiveness of the fractionation, because you can say, okay, you spare the normal tissue, but you also spare the tumor. So if you spare the normal tissue exactly as you spare the tumor, there would be no gain in doing this fractionation this fractionation regime. So the real point is that the alpha-beta ratio of the normal tissue complication and of the tumor control probability are different. Generally, for late responding tissue, for late effects, the dose response curve is a low alpha-beta. For tumor, and also for early responding tissue, for acute effects, the alpha-beta ratio is very steep. There is almost no shoulder, very high alpha-beta ratio. So this means that if you fractionate, you will spare the normal tissue more than the tumor. And this is very important to understand. I mean, fractionation works if you can spare the normal tissue more than the tumor. So it's okay to fractionate when you have a low alpha-beta ratio, but if the alpha-beta ratio is the same, you cannot expect that fractionation gives any advantage. Still, you can say, okay, I can still increase the dose more without killing the patient. This is fine, but the tumor will be spared as much as the normal tissue. So these are examples you see for early and late alpha-beta ratios for different tissues: skin, jejunum, colon, testis. Tumor tissue approximately 10, this we said already. So the alpha-beta is about 10 gray for tumors, very variable, we will see. Spinal cord, kidney, lung, bladder, you see, generally speaking, all the normal tissues for late effects have much lower alpha-beta ratio than tumor tissue. So you can calculate the alpha-beta ratio from experience, let's say, from the clinical experience. These are typical data used. In this particular classification by Chapman, the beta value is kept constant. You can, of course, alpha and beta are correlated, so you can fit in different way. One easy way to do it is to keep constant beta and to change alpha. And then you have different groups. You see, like lymphoma, myeloma, neuroblastoma will have a very high value of alpha, 0.79. But if you take, for example, breast, bladder, and cervical carcinoma, the alpha is much lower, it's 0.288. Or for melanoma, osteosarcoma, glioblastoma, renal carcinoma, even lower, 0.259. Medulloblastoma as squamous cell lung carcinoma, SCLC, have also a very high alpha-beta ratio. So we already saw the Barentsen formula for biological effective dose, which is based on the alpha-beta ratio. Just to remind you, this is the acute dose response curve. This is the fractionated dose response curve. Now, if you, in fractionated dose response curve, you apply a formula, a simple formula, assuming that you have N0 times E2 minus alpha D plus beta D squared times E2 minus alpha D plus beta D squared. Again, you ignore repopulation here. There's no repopulation in this formula. Then you immediately realize that the survival can be written in this way, which is easily written as E2 minus alpha times the BD, and the BD, biological effective dose, is D times 1 plus D, small d, which is the dose per fraction, divided by the alpha beta ratio. D, gross D, capital letter D, is n times small d. So now, in the clinical practice, you can actually calculate the biological effective dose for different fractionation regimes. Say, for example, that you have alpha beta ratio, say that is 10 gray for tumors. So, for example, if you give 55 gray in 20 fractions, you calculate a biological effective dose of 70.1 gray. Gray 10, you see 10 means that the alpha beta is 10. But if you give 50 gray in 3 fractions, the biological effective dose is much higher, 133.5 gray 10. So we expect a much higher tumor control for schedule, for hypofractionated schedule. This is clear. This is called hypofractionation, because you reduce the number of fractions and you increase the dose per fraction. You see, you have 2.75 gray per fraction here, 16.7 gray per fraction here. The problem we will see is that the problem of going into hypofractionation, we will see, is the BD of the normal tissue. This is the BD of the tumor. Another useful formula is the so-called Wheeler's formula. This is very easy to deduce from the BD. This is used to calculate the tolerance dose to the normal tissue when you go to hyperfractionation regimes. So this essentially means that the total dose in the new regime, with the dose per fraction of nu, divided by the total dose in the reference regime, where the dose per fraction is the ref, can be given by this formula. So when you have a reference dose for the tolerance dose of a normal tissue, you can use this formula to calculate the new tolerance dose using simply this formula when you change fractionation scale. And also very used, instead of the BD, sometimes people prefer to use the EQD2, equivalent dose in 2 gray per fraction, which essentially is the ratio of the BD divided by the BD at 2 gray per fraction. So you see D plus alpha beta divided by 2 plus alpha beta, so it's BD divided by 1 plus 2 divided by alpha beta. This is a little bit more familiar because it gives you an equivalent dose in 2 gray per fraction. And by the way, if you have a telephone, cell phone, whatever you want, you can easily find apps that calculate the EQD, for example, or the BD. You know, these are easily found. This is for who has the iPhone here. This is an iOS app, but there are also in Android. So now, if you assume equal effect every fraction, which is questionable, but that's the assumption, the number of cells surviving after n fraction can be written in this way, no? N equal in 0 exp minus alpha d, this is the total dose, 1 plus beta over alpha d. And this means that the TCP, the tumor control probability, can be written in this way. So you see that now you have a formula for the tumor control probability. Once you have the number of initial clonogens, that's something you have to know. You have to know how many initial cells you have. We have seen, we had to do an assumption also in our simple exercise. And then you only need to know the alpha beta ratio of the tumor. So the number of clonogens, the alpha beta ratio of the tumor, and then depending on your fractionation regime, you will have a different TCP. Now, of course, as we have noted before, the TCP is not enough. We have to see the NTCP. For example, you can do it with the Lehman-Katcher-Barman, the LKB model that we have seen already in the previous lecture. You remember this is the formula for the NTCP, where T here is a cumulative function of a Gaussian, so it's a sigmoid. And T is given by this formula, where TD50 is the 50% complication rate dose, and M is a steepness parameter, is a ramp parameter. Now, the important thing to know is that when you calculate the BD in NTCP, what happens? It happens that it, of course, will be strongly dependent on the fractionation, just like for tumors. But because the alpha-beta ratio for normal tissue is generally lower, this is what happens. You see, for example, here, this is a variation of biological effective dose BD for normal tissue, so 3 gray, for tumor iso effect. So constant tumor BD of 10 gray. For a reference regime, 20 times 2.75 gray. So now you calculate how you change, I mean, what is the BD at the same for the same tumor iso effect as a function of the fractionation. And then you see that you're reducing the number of fractions, the BD rapidly increase. So for the same TCP, you have to increase, reducing the number of fractions, you increase enormously this quantity. So eventually, you see, for constant tumor effect, as the number of fractions increases, the effect of the normal tissue decrease. So increase the therapeutic ratio. So apparently, this plot is strongly against hypofractionation, because you see, if you increase the number of fractions at the same TCP, you have a lower BD, which means that you have a lower toxicity. And then you say, okay, perfect. Let's say I increase the number of fractions, so I widen the therapeutic window. We will see that there are exceptions, but this is the rationale for fractionation. If you want, even the rationale for hyperfractionation. So if you increase the number of fractions beyond the conventional 2 gray per fraction, 30 fractions, you should have an effect. If alpha beta is 3 gray for normal tissue and alpha beta is 10 gray for tumors, of course. Now, if this is not the case, so if there are cases where the alpha beta for tumors is not really bigger than the alpha beta for normal tissue, then you start to wonder. And this can be the case for sometimes breast carcinoma, prostate. They have low alpha beta. And then at this point, you say there is no point to fractionate. I can hypofractionate, so I give high dose per fraction. So the approach in changing the fractionation scheme can be divided in acceleration, hyperfractionation, and hypofractionation. Acceleration, generally speaking, only means reduce total treatment time. This can be done, you see, by an increase in dose per week, but can also be done by hypofractionation if you want, or if you do hyperfractionation, then you have to irradiate in the morning and in the afternoon. Generally speaking, everybody agrees that the acceleration is good. It's good for the patient, it's good for the hospital, and it's good biologically because you will reduce repopulation of tumor cells if you keep small the number of the time. It is generally used, you can do acceleration in combination with hyperfractionation, which means that now you irradiate at 2 fractions per day with the justification that the late reacting tissue can be spared compared to the tumor by reduction of dose per fraction. And of course, can also be done in hypofractionation, where essentially you reduce the number of fractions and you increase the dose per fraction, but the total dose is also reduced, of course, because otherwise the BD will be enormous, too high. As we said many times, we have constantly neglected the repopulation, and this is not generally correct because it is already known that clonogenic tumor cell proliferate and repopulate. The longer treatment duration require higher dose. Generally, one should consider something like 0.3, 0.6 gray lost per day. So avoid long treatment breaks and distinguish between the number of fractions and total treatment duration. Now, you can include repopulation in the BD formula, and this is done in the so-called Fowler formula. The Fowler formula, you see, is nothing else than this. You take the survival and you write the survival as we have seen before, n0 e2 minus n alpha d plus beta d squared. But then you consider that there is the repopulation, and you describe the repopulation as an exponential function, 2, because of course it's not e2, but it's 2, t minus tk divided by tp, where the t is the time where you have given this dose, this number of fractions. Tk is the kickoff of repopulation. So it has been, it's practical to imagine that repopulation doesn't start immediately, only starts after some time, when you reduce the number of cells to the point that the tumor tries to repopulate. And of course, Tp is the doubling time of the cells, of the tumor. So you distinguish here fast-growing tumors and slow-growing tumors. So if you use this formula, you can calculate the BD. The BD comes like this one, which is the Barentsen formula, minus the logarithm, the natural logarithm of 2 times t minus tk divided by alpha tp. So this is now the Fowler formula that gives you the BD for repopulation, including repopulation. And this can be applied in many cases. This is an example. It's a real clinical trial. You see this one. It's a 4 arms clinical trial organized by RTOG. This is for head and neck tumors. You can see the details here. You see this arm is 1.2 gray times 68 fraction. This one is complicated, 1.8 30 fraction plus 1.5 per 12 fractions. This one is 1.6 times 42 fraction. And the control, let's say the classical, will be 2 times 35 fractions. So the expected, if you want, the expected BD, or this is not BD, this is EQD equivalent dose in 2 gray. So you see here, for example, you have 70 gray. So for the late complications, the expected EQD here is 70, and you see that all these hypofractionation regimes will reduce the risk of later complications. So you give a lower dose using this fractionation scheme compared to this one. So the clinical trial is done to measure this one, but you have to keep in mind that depending on the tumor cell doubling time, this is as a function of the tumor cell doubling time, assuming a TK of 21 days, an alpha of 0.35 gray and an alpha beta of 10 gray for the tumor, you have different response, different TCP expected. This is the logarithm of the tumor cell kill. And this is another example. This is actually acute mucositis in head and neck cancer. And again, you can calculate for different regimes. You can calculate the BD here. You see, using this formula. You see, for the tumor, you have TK 21 days and TP 3 days. For the mucositis, 7 days and 2.5 days. And then you can calculate, you see here is quite nice that you can calculate for different regimes using here. This is the total dose, and this is the AQD that should be then lower than 70, let's say. And that's the acute mucosal that should be less than 4952, which is what you get in conventional. Excuse me. So now the types of radiotherapy. Let's make a little break now, and we will start then with the types of radiotherapy.